Neelam, are we live?
Yes, ma'am.
So, will the events team share the slide or should I share the slide?
You can share the slides, ma'am.
Yeah. So, can you see my screen?
Yes, ma'am.
Yes, ma'am. Ma'am, we are live.
Like, Janani madam, can you start? Janani madam.
Yeah. You want me to start? Yeah, fine. So good evening, everybody. Good evening, esteemed chief guest. Good evening, guest of honors, senior faculties, and all the faculties and the delegates who have joined. It gives me a great pleasure and honor to have this webinar of Obstetric Gynec Society of Southern India, which is a live webinar on sexual health in women. We are conducting such webinar for the past 3 months, and this is a series. And we have this webinar in collaboration with the Sexual Medicine Committee of TNFOG and the Sexual Medicine Committee of EMOX. And with the collaboration of both the federation, we have this webinar, which is focused on sexual health in women, a practical approach to the clinicians to how to tackle the sexual problem in the women and give a good sexual health in the women. I welcome you one and all. We'll start with a prayer. May I hand over to Priya to MOC of this webinar.
Thank you, madam. Thank you. It's a great pleasure to welcome all of you for the webinar. One second. So I would request all the dignitaries to raise up for the Tamil Thai Valthu.
Rajeshri, audio is not there.
Ma'am, you need to stop share and you need to share along with the video.
Priya, please note down.
Madam, I have can you hear it, madam? I've muted the audio.
Yeah, you have to on. We cannot hear it.
Unmuted, Priya.
Yes, ma'am.
Ma'am, while sharing, there is an option down. You will see that share along with the audio. Just click on it and then share it.
Actually, it doesn't show for me.
Raji, why don't you help her and you can carry on?
You can share it from your side.
Neelam, please do share the screen. Yeah.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு இறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே உன் சீரிழமை திறம் வியந்து செய்ய மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you all. So, Oxy is privileged to host. You are sharing, right? Can you share it the whole screen? So, we all know that, lighting the lamp, which brings the, it takes away the darkness and brings light. And we want to bring the light of knowledge. I would invite all the dignitaries to, join us for the lighting of the Kuthavilakku. Can you just share the screen? It's better that you can share it from your side.
You continue the sharing the slides from your side. I think there's a problem with Priya's side. You can just
No,
continue.
madam, I shared, but twice they got cut it and their side has also been sharing. So,
No, your side is audio is not there. Okay, we'll go ahead with the inaugural things. It's okay.
Yes, ma'am. Thank you all. I would like to invite Dr. Kundavi Shankar, our Honorable Secretary. Madam is a well-renowned fertility consultant and she's been in the field of reproductive surgery and laparoscopy for over 20 years. Madam, I welcome you to give the Oxy prayer.
Thank you, Priya. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep a woman safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, madam. So I would like to welcome our President of Obstetrics and Gynec Society of Southern India, Dr. Jayarani Kamaraj. Madam is a senior consultant in reproductive medicine and director of Akash Fertility Center. She's been the president of Oxy and the treasurer of TAPISAR. Over to you, madam, for the welcome address and to invite our chief guest.
Thank you, Priya. Anivarikum Vanakkam. That's the wishes from Chennai and from TNFOG to all the senior faculties here. Respected chief guest, Dr. Rajendra Parasdesi, sir. Guest of honor, Dr. Milan Shah, and guest of honor, Dr. Revati Janagiram, madam, and all the senior faculties, and the Medicine Committee Chairperson, Dr. Madan Kamble. We welcome you one and all on behalf of Oxy 23 and the TNFOG. We welcome you one and all for this webinar. I have the great pleasure, pride, and honor to introduce the chief guest, Dr. Rajendra Singh Pardesi, sir, who is the president of the EMOX 2022-24, and he's the past vice president of Oxy. Sir is well known for his kindness. He's so inspirational and he's so good to everyone. And he has been encouraging everyone in Foxy, as well as he has set a model to all the people who work with him. And he has been so much kind enough to help everyone and support everyone in his vice presidency. And I really look upon you, sir. It is a great honor for us to have you as the chief guest for this occasion. Over to you, sir, to say a few words to felicitate this webinar, sir.
Thank you, Dr. Jayarani, for kind introduction. Good evening, everybody. Respected Dr. Revati Janakiraman, President TNFOG, Dr. Milan Shah, sir, Dr. Sudha Tandon, Dr. Maninder Ahuja, and conveners, Dr. Madan Kamble, and Dr. Jayarani Kamaraj, and Dr. K.M. Kundavi Shankar, Secretary of OGSSI. I am feeling proud and honored to address this joint webinar of EMOX and TNFOG. I wish to express my sincere thanks to Dr. Revati Janakiraman for taking this initiative with EMOX. First, I wish to congratulate conveners, Dr. Madan Kamble and Dr. Jayarani Kamaraj, for organizing such an academic and practical webinar, which will be useful in day-to-day practice. And both are heading their sexual medicine committee, that TNFOG and EMOX. It's really appreciating. In previous days, sexual health was somehow neglected topic, or you can say topic in the list of least discussed topic. EMOX has taken this initiative to open to public also, to aware them and to manage their sexual problems in a scientific way, as Dr. Jayarani told. Dr. Madan Kamble is our ever-active chairperson of Aesthetic and Sexual Health Committee, EMOX. Dr. Madan Kamble is very active academic and inclusive person who has attained a height in EMOX. I know personally Dr. Jayarani Kamaraj, who is also interested in sexual health of women and working in this field since long. I wish every success to Dr. Jayarani Kamraj for her future endeavor in FOXI as chairperson. I think we need leaders like Dr. Jayarani Kamraj in future. With the galaxy of speakers like Dr. Sunil Jindal, Dr. Maninder, Dr. Sudha Tandon, experts, chairperson, and panelists, I think this will going to be a great event. I don't want to be in between you and scientific content. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you so much, sir. Thank you for your pearls of wisdom. And thank you for all your inspiration. Thank you for all your wishes. And I hold my hands that I will be definitely working up to your expectation in this sexual medicine committee, sir. So I'm very thankful for being here to be the chief guest for this webinar, sir. And we look forward to do a good work along with your sexual medicine committee for spreading the academics and the knowledge of sexual medicine for all the clinicians to have a better scientific approach to all the sexual issues of the women. Thank you so much, sir, for being with us. I have the great pleasure and honor to introduce our guest of honor, Dr. Milan Shah, sir, who is the past Vice President of FOXI. Sir has been very active in the sexual medicine because we have been attending a lot of events in Sholapur, where sir is from. He is the president of IMA of Indian Medical Association, and he is the president of IZOR between 2016 and 18. And he is the founder president of Infertility and High Risk Foundation. And sir is, he is doing a lot of work in aesthetic and the regenerative medicine also. And he is the present managing committee member of IAG, and he has been a lot of initiative for the Sholapur committee. And we have a very great pleasure to have been in association with you, sir, for the past 10 years. And it's a great pleasure and honor for us to have you here to encourage us and to guide us for this webinar, sir. Over to you, sir, for your words of wisdom, sir.
Yeah. Thank you very much, Dr. Jayarani, for all these kind words. But I was so surprised and so happy to see such a great liaison between the EMOGS, the Tamil Nadu Federation of OBGYNs, and the Obstetric and Gynecological Society of Southern India. You know, I'd been to this particular society so many times that I know every city of Tamil Nadu and the Southern India societies. And that's why when I got this invitation from you and Dr. Madan, I was very happy. I said, yes, good chance to meet you all. And that to a very important topic of sexual health series. Because we understood over years, being in the same field, dealing with all those intimate organs day and night in our gynecological work, we always need to address this particular issue. Gone are the days where we used to have actually, the very ugly scars, ugly episiotomy, actually gapes, and all those things have gone now. The people are aware about the aesthetic gynecology. They want to have the beauty of the intimate organs as well, and someone need to be very bold. And that's how I was very happy when we had organized this event in Sholapur, the Blossom, the first conference in state of Maharashtra, which was very a great milestone. It was because of the contribution and the presence of all of you, Dr. Jayarani, Dr. Madan. He took a lot of interest actually in organizing that. And now the Rajendra Singh Pardesi, again I saw in EMOGS, he is trying to see that this committee also works very well. I was really very happy to meet Dr. Revati as well after a long time, because I had been to Madurai a couple of times, and every time we used to enjoy the hospitality of Madurai. I'm also happy to meet Dr. Priya. Actually, I met her once, but I still remember. Thanks to the Jaya, that I can see all my friends who are going to speak today. Dr. Sunil is going to speak. Maninder is there. We used to dance together in all conferences. And Dr. Sudha, again, we meet every Sunday for one or other event. I can see so many people from my own area as well, from my own society also. I can see Meena, Vivek and Nanda, all of them, they're going to contribute. So this will be a great event, I'm very sure. And all those people who from the rest of the Maharashtra, also Dr. Sumant, I can see Dr. Vilas, and Dr. Swati, Dr. Surya Kumar, Krishna, Malini, Dr. Jyoti Rokde. So all of that going to give a great insight on these various important problems in the actually sexuality and the women's health issues? Could it be the laxity? Could it be the menopause? And of course, could it be the infertility? Yesterday, I was discussing with one of the colleague who has come from Hubli and now joined my hospital. Recently passed out from the Hubli Medical College. And she was asking me about the PCT. Sir, how come you are continuing with this postcoital test? And I said, true, because that is the only way by which I can assess their actually the sexual function. Otherwise, quite often, they are not actually aware about this particular health issues related to the sexual practice. Even the intercurries is their thought of actually the sexual function, and we need to educate them. So this is going to go a long way, Dr. Jayarani and Dr. Madan, as far as the spreading this knowledge of sexual health in various parts of the gynecological societies. And also to all those youngsters who are going to step in for the practice, are going to take these particular messages to their home whenever they are going to start their work. I wish all the best for this particular webinar. I'm very eager to listen to all of you. I will be very much there till the end of this particular webinar because the topic chosen are really wonderful. Thank you very much for this kind invitation. Thank you. Thanks a lot.
Thank you so much, sir. Thank you very much for your encouragement, and thank you very much for all your memories and all your appreciation for all the ones who are here. And really, your words mean a lot to us. And thank you for joining us, and thank you for giving all your blessings and wishes, sir. And really, your words are very inspirational, sir. Thank you so much for your time, sir. And I have the great pleasure and honor to introduce my mentor, my teacher, and the women I look upon right from my day one in my medical college, my professor, Dr. Revathi Janakiraman Madam, who is a past vice president of FOXI South Zone, and who is the person who started everything in Madurai. She started the Madurai OBGYN Society, she just started the IMS chapter, and she started the Madurai chapter of TAPIZA. And she has been the initiative, all the inspiration for all the Madurai OBGYNs. And she is now the present president of our TNFOG. And she's so much with the dynamicity in her thoughts and in the work and her commitment to all the OBGYNs. She's a real person who everybody will look forward to work, to look upon and to work like her. It has been a great pleasure and honor, madam, to have you as a guest of honor, and we will be happy to have your words of wisdom.
Thank you, Jaya, for a very nice introduction. And it's my pleasure to work with AMOX, which is headed by Dr. Rajendra Pardeshi. Of late, TNFOG jointly with AMOX is doing a lot of webinars, which I'm sure will be benefiting all the audience. And sexual health is an area which is untouched. And Dr. Jayarani has taken up this boldly, and she's doing a lot of work on that. And it is surprising that in spite of her heavy practice, she is managing to do all this academic work that shows her passion. So that is very, very important. And I am sure that this webinar with a lot of interesting topics is going to be of much use in clinical practice for all the delegates. And as Dr. Milind said, it gives us an opportunity to meet all our friends. Really, webinars are not only in gaining academic knowledge, but also in meeting our friends. It is a good platform. And I wish this webinar a grand success. And I also wish Jayarani for her success in the FOXI election. Thank you very much.
Thank you, madam. Thank you for your nice words. And a very special thanks I would like to convey is for the chairperson of EMOX Sexual Health Committee, Dr. Madan, who has been a very dynamic person, who has been of immense help, right? Because in a short notice, we could arrange such a beautiful webinar. Without him, it is not possible. It was not possible. And Dr. Madan, you have been so much of energy to take everything meticulously to organizing this webinar. And I owe a lot for you. And over to you, Dr. Madan, for a few words.
Yes, thank you for kind words, Jayarani madam. Actually, I'm very happy to have this collaboration of AMOX with TNFOG and OXI. Actually, I'm doing first time this collaboration on behalf of my committee. And we are very honored to have guests like Pardeshi sir, Milind Shah sir, and Revati madam. It is really a wonderful webinar, and definitely the audience will enjoy all the academics. And once again, thank you for taking this great initiative, ma'am, and wish you all the best in coming Foxy elections.
Thank you, sir. Thank you for your wishes, sir.
Actually, I wanted to add one sentence for Madan, Dr. Jayarani, that when we started this committee in AMOX, we were skeptical how it is going to go, because I took as a first chairperson when Dr. Rohini was AMOX president. But after that, Madan has really utilized that particular committee in such a nice way. I'm very sure that everyone in AMOX now speaks about the aesthetic gynecology. It is creditable to Madan, you, because of your hard work. All the best.
Thank you, sir. Thank you.
Thank you so much, sir. Thank you for all your encouragement and inspirational words, sir. Thank you, Dr. Madan, for being with me to arrange all this webinar. And I'm really very thankful for all the senior faculties here, Dr. Sunil sir, Dr. Sudha Tandon, Dr. Maninder madam, and all the chairpersons here, Dr. Kiran and Dr. Manonmani, Dr. Meena, Dr. Sumant, and Dr. Vivek sir, and also Dr. Vilas Padre sir, and the young panelists, young and enthusiastic panelists, Dr. Jyoti, Dr. Krishna, Dr. Malini, Dr. Nanda, Dr. Surya Kumar, and Dr. Swati Rathod, who has accepted our invite in a short period, and very happy to be a part of this wonderful webinar. I thank you one and all for being with us. Over to Priya for this academic first session to start.
Thank you, madam. Thank you. So, yes, I mean, as a part of convener, I'm not going to introduce you again, madam. So you and Dr. Madan sir will be the part of an expert team as well. So we'll go to the first sessions for today, which will be on the pelvic floor laxity and the sexual dysfunction. So I would like to invite the chairpersons for these for this meeting. The first chairperson will be Dr. Kiran Sonwalkar. Sir is a secretary, Satara Obs and Gyne Society. He's a consultant in Sri Nursing Home, Satara, a committee member of Foxy and AMOX Society, Society as well. So, and the next chairperson for today is Dr. Manonmani Madam. Manonmani Madam is the HOD of the Coimbatore Medical College. Madam has got the Johnson's medalist, which is like 17 medals. You get it from MMC and then you get the medal. So she's been a very good speaker in all national conferences. And madam, there is a lot more to say, but we'll just directly go on to the sessions and over to the chairpersons. Madam, to introduce the speaker, madam.
So good evening, one and all present here. At the outset, I would like to thank Jayarani ma'am and team for giving me this opportunity. It is my proud privilege to introduce Dr. Sunil Jindal, who is a consultant andrologist and scientific director, Jindal Hospital and Fertility Center, and is a vice chairperson, Delhi ISAR and Delhi IAGE. He had received gold medal of best postgraduate MAMC New Delhi and had 35 awards from different organizations. He had collaboration with multiple institutions for research, including American Center of Reproductive Medicine and a national, international, offline and online master trainer. He had so many publications and presentations. He had authored chapters in 8 textbooks on fertility and 12 papers published in peer-reviewed journals, over 200 national international presentation, and his special interests are in fertility-enhancing endolaparoscopic and microscopic andrology surgery, sexual medicine, special interest in surgical, medical, and laboratory andrology. Welcome you, sir. It's over to you, sir.
Thank you very much.
Thank you, sir. I'm stopped sharing my screen. You can share yours. Can you share your screen, sir?
Yeah, I just will. Just a minute.
We can see your screen, sir.
Yeah, just a minute. I'll just function F5. I'll just a minute. Just a minute. Function F5. Testicles, testicular. I'm in a webinar at the moment. So I'll just begin. First of all, thank you very much. Thank you very much, Dr. Jairani, for the invitation. It is really kind of you that today you've given me the opportunity to speak at a time when I have such close friends over here who have been the chief guests and of course the guests of honor. Thank you very much. Dr. Milind, Dr. Pardesia, Dr. Madan. I mean, there's everybody over here. Thank you so much. So I'd like to speak about a topic which is the pelvic floor laxity and sexual dysfunction. And first of all, let's understand what's the definition of vaginal laxity or pelvic laxity. So it refers to the loss of tightness and tone in the vaginal canal. Now it can result in three important things. It can result in decreased sexual satisfaction. It can lead to diminished sexual function. And of course, a reduced self-esteem. Now, what is the prevalence? It's very interesting that when I was looking up for the prevalence, I found three major papers which talked about the prevalence which is there. And approximately 45 to 60% of women experience pelvic laxity after vaginal delivery. And the prevalence increases with one thing, the number of deliveries. And in a study of post-menopausal women, it was found that 58% reported vaginal laxity as a significant concern. Now, what's the importance of recognizing the impact of sexual dysfunction? Now, sexual dysfunction is associated with vaginal laxity, which significantly changes the woman's quality of life and intimate relationships. So one study showed that 81% of women with vaginal laxity had sexual dissatisfaction. And by understanding the connection between vaginal laxity and sexual dysfunction, a healthcare provider can provide appropriate intervention and support, of course. So a very brief overview of female reproductive system. We all know there's a vagina, uterus, fallopian tube, and ovaries. And the vagina serves as a muscular canal connecting the uterus to the external genitalia. But the interesting thing is that you have elastic and muscular tissue. And the ligaments include the pubocervical fascia, uterosacral ligaments, which provide the vaginal support to the vaginal canal. Now, during childbirth, the vaginal canal stretches to accommodate the passage of the baby. The second thing which happens is hormonal changes occur, and a decline in the estrogen leads to menopause and contributes to vaginal tissue thinning. And the natural aging process as it is decreases the collagen and elasticity, which reduces vaginal laxity. Now, the question is, what are the risk factors? So, childbirth, related factors as vaginal stretching and trauma, vaginal deliveries, especially those involving prolonged labor or large babies, can lead to significant stretching and trauma to the vaginal tissue. Now, multiple vaginal deliveries, number one, and instrumental deliveries can lead to vaginal laxity. The second thing comes is hormonal changes. Menopause and estrogen deficiency leads to decline in estrogen level, vaginal atrophy, decreased elasticity. Estrogen deficiency can lead to thinning of the vaginal wall and reduced blood flow. And age-related, we of course know, in age, it's not only the skin which wrinkles. It's not only the loss of elastin and collagen of the skin, but also of the vagina, which leads to a lesser tone and elasticity. The supportive ligaments also weaken over time, and this leads to further vaginal elasticity loss. Now, what is the impact of this? So you have an impact on sexual satisfaction and self-esteem. And a very negative body image can form, because of which self-consciousness can impact self-esteem and overall sexual well-being. The second thing which happens is it gets connected to dyspareunia and decreased libido. As age goes on, a woman has given birth to children. There is a decreased libido. And this decreased libido with reduced sensation and inadequate friction leads to a condition where there is dyspareunia and along with it, sexual dissatisfaction. The third is the psychological implication, and the importance is that sexual dysfunction leads to less self-confidence. It leads to problems between the couples, and therefore an open communication between the healthcare provider and the patient is important, which needs to be non-judgmental, and that space needs to be created. Now, what do? So we do history taking. History taking, you'd like to gather the sexual history of the patient, sexual function, sexual satisfaction, dissatisfaction. You like to ask the patient about vaginal looseness, decrease in sensation, pain during intercourse, or decreased libido. While physical examination, you would like to use appropriate tools to see vaginal laxity. You would like to see if the canal is okay. You could use a vaginal speculum, see if there is any associated prolapse present. And the patient reports the outcome. You could also have validated questionnaires as the FFSI and the pelvic organ prolapse, urinary incontinence, and sexual questionnaire. These are very helpful because what happens is that a patient once has to write. Once he has to write, it becomes very simple for you in the future because you don't have to ask those questions. Now, what are the interventions present? So non-surgical intervention, pelvic floor exercise and physical therapy, use of vaginal moisturizers and lubricants, hormonal replacement therapy for menopausal women. Now, pelvic floor exercise and physical therapy, we need to encourage our patient that these patients should perform Kegel exercise to strengthen pelvic muscle floor. And pelvic muscle floor therapists, if they are present or you yourself will have to explain for the intensive therapy. And let me be honest with you, Kegel exercise can do magic, especially post-delivery. And if every patient post-delivery is told to do Kegel exercises, a lot of problems which come over will not happen. Now, the next is use of vaginal moisturizers and lubricants. So a lot of recommended uses are there. We'd like to recommend water-based lubricants during sexual activity to enhance comfort and reduce friction. And we'd also like to suggest the use of vaginal moisturizers to improve vaginal tissue hydration and elasticity. The third, of course, is hormonal replacement therapy for menopausal women. And this is very important because it leads to patients have a lot of vaginal atrophy and laxity. And this leads to a situation where estrogen therapy can help. Just close this door. Can help. And this becomes very important for us as well. Now, next is surgical intervention. Surgical intervention is something which we all talk about nowadays a lot. So a patient could undergo a vaginoplasty, which could be a surgical tightening of the vaginal canal to restore tone and elasticity. A perineoplasty to focus on the repairing and reconstruction of the perineum. Nowadays, lasers and radio frequency procedures have become very popular. Now, these are minimal invasive and these lead to, they promote the collagenase synthesis and tissue tightening. These procedures can stimulate neocollagenesis and improve vaginal laxity without the need of extensive surgery. But well, number one, these instruments are very expensive. Number two, how much they actually are going to help is also something which we need to understand. And there are newer technologies like vaginal regeneration, regenerative medicine like PRP is used, fillers are used. These all are options which need to be given to the patients. So now what do you actually do? You address the patient's concern and misconceptions. So you really have to give time. I think more important than the laser and the surgery is giving time to the patient to really understand what they want and suggest the outcome. Number one. Number two, an open communication should be there to explain to them what exactly can you do and what should they expect. And the third is providing realistic expectation of treatment outcomes. See, there are three things which get combined together. The laxity with loss of libido. And along with that, in these patients particularly, you may also have dyspareunia with less lubrication. For these people to understand, and at this age at times, also the sexual partners have problems like erectile dysfunction and premature ejaculation. So it's a combined story of everything. Now at this time, if you promise these patients or you overpromise them that everything is going to be fine by using this particular instrument, they will be highly dissatisfied if it does not happen. And if you explain to them that the only thing which is going to happen is this, we will combine this with this, and it's going to give you better sexual satisfaction, that is where these patients will remain happy. So you cannot overpromise. In fact, you have to underpromise and overdeliver in any of these patients which come to you. Now, I'd like to present two cases over here. So Komal, 35 years of age, who recently gave birth to her second vaginal delivery. And she's a young patient. And she's been experiencing a significant decrease in vaginal tightness, and her husband complains about it. And there is less of satisfaction after childbirth. And Komal is bothered by these and greatly bothered, and she wishes to improve her sexual function and overall quality of life. So now with her, probably the answer which we would normally do with her is, first of all, tell her about pelvic floor exercises and physical therapies. If every woman after delivery is told that you need to do Kegels to strengthen your pelvic floor, enhance vaginal tone, improve sexual function, that's the first thing which they need to be told. The second thing is, a lot of time that vaginal moisturizers and lubricants are needed. Any good water-based vaginal lubricant during sexual activity enhances comfort. At times in the mind, the laxity which they feel, which enhances in their mind, especially if the male partner has said this is a big problem, along with it, the dryness and this less of hydration leads to something in the mind where they actually connect the dryness with the laxity. So lubrication needs to be given, and the person needs to be counseled that this is a normal change which happens. Have realistic expectations. And you can also provide some realistic information to these patients, which will be very helpful. Now, the second patient could be Anita, who's 55 years old, postmenopausal, who has been experiencing vaginal laxity and associated sexual dysfunction for several years. And she has no decrease in sexual desire, painful intercourse, reduced vaginal sensation. These issues have caused her significant distress and affect her self-esteem. Now, if a patient comes to you, you've got to do something. She's 55 postmenopausal. You really have to think whether you'd like to do HRT, which could be contributing to, the less hormones could be contributing to vaginal atrophy and laxity. You could prescribe some estrogen therapy, vaginal creams, tablets to restore the vaginal tissue. Laser and radio frequency is a good procedure in these patients to promote collagenase synthetase and tissue tightening. And they improve the laxity. And the third thing, of course, is you've got to counsel and speak to them. You've got to tell them what are the outcomes. You've got to tell whether tightness is going to improve or not, and they need to be followed up. So the key points which I've discussed over here is it's a common problem. Prevalence is high. It gets associated with other things to become a major problem. Early detection and intervention, just like after delivery, is most important. And if we encourage a multidisciplinary approach and we have pelvic physiotherapists to help them, I think our life would be much simpler. So thank you very much for the time. And thank you very much, Dr. Jayarani, for giving me this amazing topic to speak to you. Thank you so much.
Thank you, sir. I would request your chairperson to give a closing comment.
Thank you, Sunil, sir, for giving wonderful explain regarding sexual dysfunction and laxity. Sir has given one message. Every patient after birth should be do Kegel's exercise to strengthening the pelvic floor muscle. Very well explained. Counseling is most important in this, and do not give the over promise to the patient. Also give the under promise to patient for good satisfaction of the treatment. So thank you, Sunil sir, for giving wonderful lecture on sexual dysfunction and laxity.
Thank you very
Dr.
much.
Kiran,
Thank you.
sir. And Manunmani madam? I would like to call Dr. Madan sir to give us expert opinion.
Actually, sir has elaborated everything in detail very nicely. Just I can say it was really wonderful. You have covered all the things in short and finished in time also, and it was really very informative. Thank you, sir.
So I want to just ask one question to you, sir.
Yes, please.
If a patient insists on a surgery of a very lax pelvis, what is the best way that you will do and how you will follow her up, sir? Because many a times in past, we see a lot of patients doing the colpoperineography, which is a way to tighten the vagina, lax vagina. How far is implication and what is the outcome of it?
No, I'll be very honest with you. We've had a lot of patients who come for this. The first thing is counseling them and explaining to them and calling them with their husband. See, what happens is a lot of times they come without their husbands. When they come with their husbands, you know whose problem is it? Is it her problem or is it her husband's problem? First thing. The second thing, important thing is what happens is if they really need a perineography, in that condition, giving them a perineography does no harm. In fact, they feel psychologically very happy. And for that, what we normally do is we always tell them that please check with your finger how is it exactly before surgery, and please check with your finger how is it after surgery 6 weeks after that. Now, this particular feeling that the laxity has gone away is a great, I would say, satisfaction point for the couple. So these patients who insist on it and need it, I mean, I think the best thing is to operate on them.
Thank you, sir. Thank you, sir.
Thank
you.
So
how far is the pelvic Kegel's cones that they use for this self-retaining exercise? How far it is helpful for in this patient?
I mean, madam, we have never used it. I'll be honest with you, but cones are available. I think probably cones give an idea that you have something to hold on to, and probably psychologically it becomes very happy, because if you ask a patient to do Kegels 20 times in the morning, 20 times in the afternoon, 20 times in the evening, it probably becomes very boring. It probably becomes a whole system of putting in a cone and using, which probably becomes an exercise which becomes more comfortable. I mean, it's once again a mental game. We've not really used them. But I know of a few people who use them and they say it's very useful.
So very important for a gynecologist, we have to repair the vaginal delivery tears, which should be given a good pelvic support. That's very important that we should do from the gynec point of view in any obstetric deliveries. Correcting the episiotomy wound in the best way of a perineal repair will give a good tone that may make them to replenish or make them to go for a better strengthening of the vaginal mucosa. That is the one important thing that we can do as a preventive measures. Am I right, sir?
Madam, when I was a registrar, one of my consultants used to say that please give stitches properly on the abdomen because it's the signature of the patient, of the doctor, and in the vagina properly because it's the signature for the couple. So I honestly feel it's the most important thing. And we think that doing a great surgery, I'm talking about myself, at times when you, after 3 hours of a surgery, you think you've done a great surgery. And when it comes to stitching back the skin, that is something you become very casual about. And I have realized that's the only thing the patient sees. So episiotomy has got to be stitched properly for the couple and the sexual intimacy in the future, even visually, apart from the fact that laxity shouldn't be there.
Thank you, sir. Thank you. Thank you for your enlightening lecture, which is really a very good, informative and very nice way of presenting, sir. Really, it's good to all the audience to hear it, sir. Thank you so much, sir. Thank you for being with us.
Thank you very much, ma'am. Thank you very much.
Thank you, sir. And we'll go to the second topic for today's discussion, which is menopause and women's sexuality. I would like to invite the chairperson.
One thing I just want to tell you, Madam is little held up in a case. If possible, can we have the panel discussion next?
Now?
That is, yeah.
Okay, ma'am. Okay, fine.
I've informed Sudha Madam also. If all the panelists are there, we can go ahead with the panel. And Madam will join a little around 8:30 so that we can finish up the panel. So she's held up in a case. So she'll be joining with us. So we'll go ahead with the panel.
Yes. So the next topic for today's discussion, we'll go ahead with the panel, infertility and sexual dysfunction. I would like to invite the chairpersons for this, Dr. Vilas Pattareka, sir. He's the president, Satara Obs and Gyne Society. He's a director of Jeevan Sakshi Hospital, Satara. He has 25 years of experience in Obs and Gynecology. He's a faculty in various conferences in the areas of interest in high-risk obstetrics. And the next person is Dr. Vivek Pikar, sir. Sir is the president of the Solapur Obs and Gyne Society. He's presented papers in various state and national conferences, and he's worked as a lecturer in Obs and Gyne department at the VM Medical College. He's a director of Bikar Maternity and Nursing Home Solapur, honorary treasurer of the RCOG, and the secretary at 2008-9 of the Solapur Society, treasurer in 2013-14 in the Solapur Society, and won the Best Paper Award in ASCOG. So, and Dr. Madan sir will be the expert. And over to the chairperson to introduce Dr. Jairani Kamaraj madam will be the expert for this panel. So it's over to the chairperson to introduce Dr. Sudha panel. Sir, Dr. Vivek sir.
Hello, am I audible?
Yes, sir.
Am I audible?
Yes,
yeah,
sir.
But my camera is, I think, not working. But so today's we start very interesting and very informative panel discussion. So moderator is Dr. Sudha Tandon. She is Joint Secretary IAG to 2020-24. She's HR committee member MOJ and MOJS. She was organizing chairperson of MOJS IAG Indo Art Conference Workshop Mumbai. She was past for Foxy chairperson sexual medicine faculty at IMM MSc. She was felicited on Chair Teachers Day by MOX in 2021, and she was winner of best presentation.
Thank you. I think we can go ahead. We can go ahead. Yeah.
Yes, ma'am.
Thank you so much for your kind words.
Yeah. Ma'am, you would like to invite your panelists?
Yeah, please invite them and put their CVs.
Yes, ma'am.
Yeah.
Madam, I think we can go ahead with the panel, ma'am. I think all of us are familiar.
So I would like to invite Dr. Jyoti Rakode, Dr. Krishna. She's a consultant from Nagarkoil. And
that's enough.
Okay, Dr. Malini. She's an assistant professor from Karur. And Dr. Nanda Satish Magai. Madam is a consultant from Mumbai, and she's having 28 years of experience. Dr. Surya Kumar Kandre. Sir is from the Pune Society, and he's a consultant in Obs and Gyne sexual medicine and a laparoscopic surgeon. And Dr. Shwati Rathore, madam, is a consultant from New Delhi. So over to you, Dr. Sudha, madam.
Yeah. So can I share my screen? Thank you for your kind words. Can I share my screen?
Madam. Yes.
Yeah. At the outset, I'm really happy to be moderating this session. Thanks to all of you, and especially to my dear friend, Dr. Jairani, and wishing her all the best for your forthcoming elections. I must say that she's extremely well-versed with the topic, and she is the right candidate for the Foxy chairperson. She has been really hardworking, and during my time, we did lots and lots of projects together. And it was a very good, bonding that we had. And I'm happy to be here to moderate the session. So I'll just share my screen. Is this fine?
Yes, ma'am. Visible, ma'am.
Yeah. So this is a very relevant topic. Dr. Sunil Jindal did an extremely great job. In the previous talk, I was listening to him, a lot of good practical tips that we got from him. And so is the issue of infertility. And, there are a lot of so many things that we fertility specialists will just jump to doing tests. But something what is really required is just a plain simple history taking, and there you will come to know as to what the problem is. So right from basic to issues or sexual disorders, we will learn in this panel and educate ourselves. Right? So, yeah. You see, the infertile couple, they'll keep trying month after month. And there'll be so much of concern, anxiety, guilt, blame, anger, not becoming pregnant. And they can have so many invasive and expensive investigations, treatment, where the treatment could be very simple, clear questions about the sexual lives, which may elicit what the cause of infertility is. And what you would require is probably just give them some time and look into that. So 15% of the couples with fertility issues, are seen, and out of that, sexual dysfunction was seen in 43%, and men it was 31%, and 12% had both the partners had a sexual problem. So that is the the intensity of the problem. Yeah. So let's go to the first case, a very simple case, which normally we see a 27-year-old lady. She's been married 3 years, trying for conception for last 2 years, and everything is fine with her menstrual history, clinical examination, semen analysis, sonography, everything. And she also has intercourse twice weekly. So we may just tell them that possibly the stress of having the sex or intercourse during the peri-ovulatory period is so much, especially on the husband, or the wife may complain of pain and lack of lubrication during the peri-ovulatory period. So, we can just tell them that you have relations on these days, but practically speaking, it may not be really possible. So how do we find out? And, since this is on webinar, any of the experts can start speaking. So we need to know whether there is a coital factor of infertility. Yeah. How will you evaluate the coital factor? Anybody can start.
Yeah. Ma'am, I think history taking is very important. Also, yes. I think over the years, because I have worked in rural Tamil Nadu and Maharashtra as well.
Yes.
I think a lot of time we have to find out, especially if the woman comes to us after a couple of years and she's very hesitant about us examining her. I think that is very important as well. And yes. History, yes. I think it's very important. Nothing, especially in a sexual history, needs to be elicited. That too, like a very, very, we have to keep a straight face. It needs to be business. And they shouldn't have any issue with any of the body language that we have. I think history remains the mainstay of to find out a pivotal problem of sexual coital factor in infertility patients.
Yeah, I think, Krishna, I really have liked what you said. Have a straight face, not be judgmental. Do not have your body language should be that you mean business. I think these are very good take-home messages, because they should, start feeling comfortable. They should be confident in their treating doctor. Otherwise they will hide if you start judging them. I think that's a very important point. So in history, what is it that you would like to? Anybody can answer. What is it that you all would like to ask? Sexual history, fine, but what in that? Because you need to go deeper, you need to really find out. So what in that? Yes.
You should ask them how frequently they have sexual activity, and also their profession is also very important, because nowadays the IT professionals are having problem with the working hours, and so they may have issues like they may not have arousal or even desire to have the sex at that time. So their occupation also is very important. And mainly the factors which count is the arousal, and also lubrication is very important. But that is an older, so foreplay plays a very important part. So we should ask them about that history also.
Yeah, I think what you said was very right. Whether they are having time for each other to have sex or whether they consider having sex important. I think that's a very important point, especially with the mobile phones. People are so much addicted, and I feel almost married to their mobile phones and laptops, or to watching all sorts of movies on the OTT platform. So I think that is to give time to each other. It may not be just sex, but connecting with each other, that will create the interest and the arousal. What else? Anybody would like to comment on this?
Ma'am, I would just like to add one point. I think Madam said working hours is also important, because a lot of people, especially, they feel with the IT industry, they work at nights. So often this is a major problem. Or if they are a police person, they have night duties. So I think the duration of the timing is also very important. And I think the penetration is a question that we cannot avoid at all, for both the man as well as the woman. Recently, I had a patient who was 5 years married, and I realized the man actually did not know what he was doing. So, and they had come with 5 years of infertility. But I think the procedure, especially when it comes to rural people and who come with us to infertility, and you are suspecting a problem, I think you need to ask this question.
Yes,
on the methodology of having sex.
Yeah, I think that's a very, very relevant point. Why in rural, even and sometimes in metro cities, they may be not aware of what is a normal sexual intercourse. So probably you should look into that also. So I think we have discussed very good, important, practical points. Anything else that anybody would like to talk about here? Because there are lots that we need to discuss and go further. Dr. Jairani, as an expert, do you think we have missed anything?
Yeah, this is regarding, you have completed everything. Regarding the coital factor, very important, we are looking into a women with infertility. So always we must ask for their, because many a times, as you rightly pointed out, they'll be always focused on a timely, the ovulation, the LH gate, all those things they will be taking into consideration regarding their ovulation time. So this makes them go for a major stress both for the men and the women. So definitely the peri-ovulatory erectile dysfunction, sexual dysfunctions are very common among these women, among this couple. So when you're asking for the sexual history, we should ask, was it painful? Whether there is any other factors that they should say, because sometimes, as pointed out rightly by Krishna, there are very many patients who come for fertility treatment who have not consummated the marriage at all. Yeah. There has been a lot of patients who come with an unconsummation.
Yes.
Yeah. So all those things you have to ask, how far the penetration, was it painful, was it deep? And when you are examining, you have to see what is the vagina, how it is, whether it is very tight, whether the hymen is intact. All those examinations are very important. Sometimes you can do a period easily, but when you want to put a speculum, it will be really painful. They will not allow. So such type of a patients may have a problem with the penetrated sex. So all those things are very important. You have talked everything very correct.
I think let's go ahead, because there's lots that we need to discuss.
We should also ask about the history of any medications, because some anti-diabetic drugs may lead to loss of libido.
Yes.
Increased libido.
Yeah. And, any medical history. Yes, I think that's very important. Diabetes, hypertension, obesity, or and epilepsy, thyroid. Yeah. So all these things, I think we should find out and really look into that and see whether that has been corrected. So let's again, again, the couple may not have given importance to sex in their relationship, and they feel that getting pregnant is very simple, and they may not really give time. They may have just intercourse on the weekends, and probably that they need to realize that the frequency of intercourse really is very important. So this is about the frequency of intercourse, that if they have once per week, the chance of probability of conception within 6 months is just 17%. But if they just have on alternate days, they need not sit and calculate their ovulation. They need not do any test, but just have sex 3 times a week, and the chances increase to 50%. I think this is a very simple thing that we can, we can talk to them. So, and of course, why this peri-ovulatory sex is very important, because the ovum, the egg, the life expectancy is just for 1 to 2 days, but the sperm can survive for 5 days in the female genital tract. So this is, I think, that we all need to know. And I think this peri-ovulatory sex, we'll do the sonography. We'll say, okay, you take your HCG injection now and have intercourse, or you come for IUI and give your semen sample. But there's so much of performance anxiety in men that they may have erectile dysfunction. So what is important at this time? What is from the point of counseling, from the point of view of connecting with them and trying to explain to them, making them comfortable? I think just few points over here, and then we'll go ahead. Anybody can speak. So there is.
Sorry, madam.
Yeah, please go ahead.
I thought nobody was answering. Anyway, I think we, as infertility specialists, contribute a lot to their libido. I mean, that goes without saying. That goes without saying. So I think when they come to you as a couple, we need to tell them there will be times when we will ask you to have intercourse, and you should be mentally prepared for it. I think that's a very important thing to tell the husband as well as a wife when the couple comes to you, especially for infertility treatments, because sex on-off mechanism does not work, and especially I know you have experienced it. I have experienced it as well. We all wait for the sample on IVF days, and sometimes we don't get it from the man. So the performance anxiety is something that we need to counsel at them and take very much in length. And I think that is something that we need to, as infertility practitioners, we need to look into.
Yeah, I think it's very good.
Very, very importantly, we have to have a proper consensus in this, because most of the time in the past, almost all the gynecologists says start from day 10 and go up to 20. So the couple stop. They do only those time, and all the time they are more concentrating on the days and dates, and that makes them really go for a stress. So ideally, we have to give them the proper counseling that people who have more than 15 to 18 times have 84% chances to get a pregnancy. And the sex is something very much a natural process of proper sex will give you a pregnancy. The more the number of times you do sex, the better the success. And all the more when they abstain for a longer time, the quality of the semen also will come down. The sperm motility, the sperm, quality, everything will get down less with a more number of abstinence. So all these scientific facts you have to tell them and ask them not to combine this with the treatment at all. Treatment is something, the follicular study, everything is for the monitoring. It is not to fix up a date or day for sex. Make sure that do it as a regular basis, a routine basis, which don't combine with this study. That will give them a better success. So very important, as you rightly pointed out, we have to do a lot of counseling, give them a lot of data, and give them more assurance of a frequent sex. That will help them to have a better fertility outcome.
Yes, I think you have really hit the nail on its head that, you don't have to just do it on those days. It should be a regular thing, and do it every alternate day, because that will not put sorry?
Extra some say.
Hello? And there are times, I think even the point of, taking a backup sample of semen, I think, which Dr. Krishna mentioned, especially for IVF, I think that is routinely done everywhere because it's extremely important. We don't want to land up with a situation where we have got the eggs and we don't have the sperms. And this I think has been very well told by all the experts over here. At times, we have to really find out whether they have the performance anxiety, and maybe a sildenafil tablet around ovulation could help in some patients with erectile dysfunction. So with that, I think we have finished everything. About anything else that any of the experts, any panelists would like to add, because I think we have covered history taking and the important practical points that we need to tell. And what Dr. Jairani said about abstinence, they feel that if they don't have sex for 15 days, the quality of the sperms is better. On the contrary, you have to keep banging into them and telling them again and again. So that sort of rapport with your patients, I think, is very important. Only then they'll be confident that they'll feel comfortable with you. So this is why there is sexual impairment, planned sex, painful tests, extensive tests. I think when we need to do, we should do. We should not otherwise do these tests. Intense feeling of anxiety, personal issues like sex being externally controlled by the physician. There may be some who do not like. So I think speaking to them constantly is important. Communication is between the couple, anger, avoidance of commitment, or also blame. It's because of you that this happened. So if that starts, then probably any partner can go into a shell. Confused priorities. It's all right if they cannot do it at one time. They can have it maybe the next day. So I think that's very important to tell them that they really need to be calm about it, and a few emotional rewards, etc. So how do we take care of these patients? There are a few things. We can have a score where we score the desire, arousal, lubrication, orgasm, satisfaction, and pain. And if you have a score of 6 in each of the columns, so you have a maximum score of 36, probably this is the best thing, and then you do not have any female sexual problems. But if you have a score, cutoff is 26, if you have something 26 or less than that, probably there is some problem with the female sexual issues, and you need to look into that and discuss sexual problems with a physician, and the tips for infertile couples on keeping sex enjoyable, not as a task. They should enjoy it. And foreplay and communication between the partners becomes very important, that when they do that, they feel like having intercourse. And quite often, just by increasing, because I've seen even during COVID time, patients on whom we had advised IVF, there were a few couples who just came with a natural conception in that time. So probably when they give time for each other, they really get pregnant. You can try erotic books, erotic movies, board games, videos, etc. Be more creative, more of foreplay, and encourage discussion. I think we have looked into all that.
And also in an African country during COVID, madam, the women asked the boyfriends, because of having sex multiple times a day, they asked for this thing to be taken off. So that also happened. I read about it in a few of the African countries.
Okay.
Because of the home, the whole day they were sitting in the house. So because of COVID, so that was also a problem. Like you rightly said, I think we had a lot of patients during COVID times who came with natural conceptions.
Absolutely, yeah. So I had a 42-year-old couple on whom I had done an IVF about 6 months or 1 year before that. And she didn't conceive. She had lost one of her child. So, at 42, I said, let's do an IVF. She didn't conceive, and then she came later on with a natural conception. So you were like, wow, that's great. Yeah. So I think this point, an ethical dilemma, I would just like to make a mention here. It may mask more severe psychological or marital problems. And at the same time, additional medical treatment may strain individual or couple. So you have to balance between what you're offering to the patient and, and also find out if there are any severe psychological or marital problems, and not push them if they're not ready to get pregnant, because unless you speak to them individually, sometimes this may be masked. I think this is a very important slide, which I feel was made sense. Okay, so we go to the next case. Any other point that we have missed? Because I think history taking to me is and managing at that point is very important.
We should speak to both of them separately and take both of them together, because sometimes there may be minor things like appearance of the external genitalia, which the partner may be commenting, which she may not like. So we may treat that may be the cause of their not having sex.
Probably, yeah. There could be a lot of underlying causes of not liking each other. So unless that's a very good point, separately and together. So we'll go to the next case. She's 27, married for 10 months, is unable to have sex, averse to sex, and even on suggestion of gynec examination, she is extremely uncomfortable, unwilling. And when you take her on the examination table, she'll keep her thighs abducted, and really even the hips, buttocks, she'll lift it. So obviously we have a case of vaginismus. So what is the history that you would like to take? And the diagnosis is severe vaginismus. What is the social and the psychological impact, and what is the incidence? So this has been described and introduced by Marian Sims, who says it reflects like contraction of the vaginal musculature resulting in non-consumption of marriage. And it will have a lot of negative effects on the mental health. Affected women can be depressed, dissatisfied with their home life. And this magnitude of the problem, the overall effect could be like diabetes and even back pain. So this is quickly just to know the female sexual disorders. This is how it is classified: sexual interest, arousal disorder, orgasmic disorder, genitopelvic penetration disorder, and persistent arousal disorder. So what is your experience about vaginismus? How often have you seen it? How do you treat it? How do you start investigating? How do you get into that comfort zone with the patient and the couple of making them confident that they have come to the right person? Anybody can take this. Yes?
First of all, we have to ask about vaginismus is primary or secondary. We have to classify it.
Yes.
If it is a primary, that she from first act of sexual intercourse, it is called as primary. Secondary, there is a pain-free penetration period followed by vaginismus.
Okay, so suppose it is primary.
If it is a primary, we have to take a thorough history. And in thorough history, we have to ask about whether any sexual abuse or she has experienced something. That history has to be taken out. Then we have to take other component, clinical examination. Also, we have to take in consideration to rule out the local pathology.
Okay.
In case of
local pathology. Local pathology is like what can give rise to vaginismus?
Like infection, inflammation, or some sort of trauma. All those things we have to think in these cases.
Yes. Sexual molestation at a young age can also be yes. So and basically when this it's basically the fear in their head. The fear of vaginal penetration gives rise to involuntary muscle spasm, pain, anxiety, humiliation, giving rise to infertility. And sometimes couples don't come they go into that comfort zone even for a few years. And when they come, they're already 34, 35. And then so much of pressure is there on them to get pregnant. And that is when they start coming and they give this, history. So organic causes we have discussed. This is the grades, grade 1 to 5.
It come under grade 4, this case.
All right.
And I'm not grade 4.
All right. So how will you manage is what is important. You have diagnosed whatever is and it's a case of primary vaginismus. So anybody can take it. How will you, how will you handle this case?
First of all, we have to go for a sex education in this patient.
Mm-hmm.
Then we have to give her good counseling. We have to make her familiar about sexual anatomy, all these things. Then we have to give the cognitive therapy in these cases might be beneficial.
Right.
And if it is a severe form, then you can go for a drug like botulinum toxin injections.
Okay. But before that, suppose, before that, is there anything else that one can do? Some form of exercise, subdilators?
I can take this question, ma'am.
Sorry, Krishna? Yes, please go
I
ahead.
would like to take this question as well. I
Yes.
think, first of all, telling her, especially today when I was doing some literature review, I discovered something known as it was hereditary vaginismus.
Okay.
And now hereditary really made me think. So there was a case where the mothers used to counsel the children, especially if they are girls, about, it is not a very, especially if she has had a very unpleasant sexual history. So that's very important. So to tell them this is not a dirty area, to make them accept their vagina as their own. I think that remains one of the key points in treating vaginismus.
And that starts right in from their teenage or even before that, So I think that counseling and conditioning is very important. Yes, please go ahead. It's a very good point that you've brought out. Yes.
Educated or uneducated is not a point, because one of my seniors, she was MD gynec, but for 1 year they did not consummate because she had heard somebody had a very painful first night.
Yes.
So it can happen to anybody.
Very true.
Yeah.
Counseling is very important.
Yes.
And then the whole drama of the blood coming out, and I think that just prevents so many of the girls from actually consummation.
The films are actually spoiling.
I think too much of movies.
Yeah.
I think
and too much of movies, and especially from the maybe mother-in-law and the husband, they would want it. Otherwise, they would have their doubts in their head. Yes, please go ahead. Yeah.
And also, I think the touching of the vagina, I think it has to start from there to make her comfortable. And if she cannot touch it and feel comfortable with it, nobody else can. She will not allow anybody else to touch it. I think it has to start from there.
Right.
So ideally speaking, it is actually a phobia of penetration. Everything will there won't be any problem per se in her. And that is a very important point that we should see in this vaginismus patient. They won't have any other complaints except that they have a problem, as rightly pointed out by Madam Sudha Madam. It is only the fear in between her head, that she has a fear of phobia of penetration. That's very important. So we have to give her a proper counseling, as pointed out by Dr. Surya Kumar and Krishna and all. We have to educate them, tell them about the anatomy, make them feel it. They themselves can feel it. They can give a lubrication or anesthetizing gel, ask them to feel their vagina, which will give them a confidence, and also the fear what they have in the back of mind of the phobia can be better relieved. And then you can advise them to go for the serial gradual vaginal desensitization in the form of a self-dilatation, which is the first important treatment part that they've given. Almost many studies have proved that that is the first step of treatment that we should advise them.
Yeah, I think the dilators, and they are available in serial dilators starting from the smallest, and then you have about 4 to 5 of them. And the severe cases may not be comfortable to do it on their own. So initially you have to call them to your clinic, and either you do it or your assistant makes them comfortable and teaches them how to put the dilator, makes them confident. I think that fear of pain is so much into their head that the first step, it's like when we learn swimming. The first dive that we do, some may just do it one day, some may take about 15 days. So I always tell them that it's just like any other act that you learn, whether it is driving or swimming, and you should not have the fear in your mind is so much that it will really not allow them to, proceed slowly. And dilators are very good. I also, sometimes I have asked the husband to be at the same time where you're examining, and the husband's her own finger or ask the husband to use his fingers. So that way they also develop a bond between each other and the confidence comes. So it depends on the level of severity that one can also, use. She can use her own fingers or the husband can use his fingers. Of course, washing his hands and wearing gloves and etc. All that, and using some sort of moisturizing lotions and is very important, because otherwise they will just not allow. And by and large, the success is quite good with this sort of serial dilators. And sometimes you would have to use Botox, that is only occasionally. And but just by Botox is not going to really be of the only thing. After that, also they would have to use dilators and get over their own fears. With that, yes.
Yeah, sorry to interrupt you, but if we are talking about a case of primary vaginismus,
yes.
So if a history of an abuse has been elicited, or you think very very strongly of a history of abuse, psychiatric evaluation and therapy, I think sex therapy to overcome this fear, sensate focus, the works. I think that is also a very...
Yes. Yes. So anti-anxiety medications, antidepressant, tranquilizers, consultation with a psychologist or counselor, all that would depend on the severity of the case and what the reason was of vaginismus. Anybody else would like to add over here their own experience, or we'll go ahead? These are the dilators. So we'll skip this. So now this again is a case of unconsummated marriage, which we see quite common. It may go on for 2 years, or even sometimes they're so comfortable for 8 or 10 years that what this is, we're just interested in getting pregnant. So by and large, it is a case of, most often it is a case of non-consummation of vaginismus, which then leads to unconsummated marriage, and probably maybe more seen in that's what I feel, when there's a love marriage where the husband doesn't want to give any sort of pain to the wife. So this is a very important cause of infertility, sexual dysfunction. And is this problem very common, and how do you tackle it? Anybody can take it.
We have to find out the cause of unconsumation, first of all, whether it is from the part of female or from part of male.
Yes.
In most of the male case, it is because of erectile dysfunction. It might be because of premature ejaculation. All these are more important factors from male point of view. From female point of view, we are already discussed. Vaginismus is one of the cause of unconsummation of marriage. And we can think about other any pelvic pathology also in these cases.
Right.
It's usually found in educated more than non-educated.
Anybody else?
Lack of sex knowledge is in these cases.
Is it not seen in uneducated? Anybody would like to comment?
No, ma'am, it's definitely seen in
both.
Not necessarily. Education is not necessarily related to the to consummation or non-consummation of marriage. Recently, there were many, especially now there is a couple, I think I just recently read. The wife is an IT person, the husband is a pilot. 7 years they've been living together. Both of them have a perfectly good marriage, but they prefer to have an asexual marriage. Now, in my head, I wouldn't know what an asexual marriage is, but that is a terminology I came across today. So, and I had a patient, she was married for 3 years. She was married to her uncle. I think in Tamil Nadu, we have this mama, the mother. So she came to me and they said, the mother, having had that, and they were very insistent, no, a child will make this marriage okay. And the husband was very easily, he gave us a semen and she became pregnant during the first time. She had, we did an IUI on her because that's what she demanded. She conceived, and now they're saying they look after their child. Now they had a second child, but still no intercourse. So this can definitely happen.
Yeah, anybody would like to add here? Because sometimes it is very difficult to make them understand, or you feel that, are you breaking your own head by trying to tell them what is normal? But I think you sometimes have to just leave it at that. But probably most of the couples want to, have sexual intercourse and want to correct it. And what I have seen is it starts with the female vaginismus, and then later on the male then has erectile dysfunction
because of it. Secondary
to what because of vaginismus is what I have experienced in my cases.
I have.
Yeah. So I think we must address this. We must realize it as primary physicians and gynecologists, and we have to look into this and ask them direct questions and try to really correct it. And they would just Google and find out, and probably that would really not help. So this we have, we have addressed. Also, one must find out whether, I think that secondary is what one has already talked about, whether they are comfortable with some other partner. That also we really need to look into. Yeah, because cannot take it for granted. Yeah. So this is what we have already, we have discussed, and it's the same thing which is being written over here, which is coming in the slide. Intact hymen. Also, there's so much of, issue about the small tissue, about the hymen in the heads, that they wanting the wife to have some sort of bleeding during the first intercourse. It plays on their minds, and probably it becomes a really hell of an issue. And sometimes you may have to repair it surgically so that they are satisfied. But I think nowadays it is not so common. That this issue is probably not so common. That is what I feel in metros. What is it? What is your experience about hymen? Is it very commonly seen, or it is?
It's not common in my
experience. Not that common, yeah.
Not that common. I think what we feel, or what has been given in the books, probably I feel it is not all that common. What we see. Yeah.
But I had gone for aesthetic gynecology training.
Yes.
And there we saw many people at the age of 40 coming for hymenoplasty.
Oh, they must be having getting remarried, or in some particular community, I think they would want it that way. Yeah. So I think foreplay and use of creams, especially in perimenopausal and postmenopausal women, is very important. I think we should also look into our own literature and look at different positions that have been told in our books on sex from the Indian literature. And there are a lot of other positions that can be used. But of course, non-consummation of marriage can cause severe marital distress, frustration, and sometimes even can land up into divorce. And it's called as honeymoon impotence. And erectile dysfunctions was seen in about 80%, premature ejaculation in 12%, lack of sexual desire about 4%. Homosexual orientation is something that we must keep in mind, because they may get married for the society or for the pressure from their parents, but probably they may just not be interested. There have been such stories also that we need to look into that. Yeah, there could be sexual aversion in some, and preferences, disorders of sexual preference. These are few rare issues of non-consummation, but we really need to look into this. And female vaginismus is the most common, 95%, sexual aversion 2%, desire 1.8%, lesbian orientation, the same thing. So basically, it is vaginismus in the female and erectile dysfunction in the male. But we need to look into other factors also when we have such couples. And myths. I think sex is equal to intercourse.
Should be initiated by the male.
Male. I think women should not initiate sex. Probably that's something which needs to be talked about. And there are a lot of now videos on YouTube and all that where women are talking about it. But still, I feel somewhere that needs to be corrected in our society, that women also have the desire and it's okay and it's fine if they initiate sex, is what I, personally feel. Respectable people should not enjoy sex, should not masturbate. If sex is not good, something is wrong with the relationship. So this we have talked. Suhagrat should be read. Its size does matter.
Suhagrat should be read. Psychological.
Yes. So we really need to have good communication, misconceptions dealt, foreplay as an enjoyable alternative. So we need to look into sensate focus exercise.
I think turning off their phone when they're having sex contributes to an important part these days, madam.
Absolutely. Giving time for each other, and, otherwise they would just have dinner. And of course, life is not so easy when they both come very late after their work. They may not be physically comfortable to have intercourse, so they can have it any time during the night or in the morning hours. Also, we need to be really telling them. And of course, religious priests to drive away the evil spirits and crafts. I think that also we should, that this could be an important point in some families, that they would take them to a priest or some pundits to drive away the evil spirits, where what is required is probably just speaking to them and giving them time and to each other. The role of counselor, absolutely very important. I think if we don't have time as gynecologists, we should be giving them, seeing that the sex counselor takes care of them. Sildenafil also a very good drug. Of course, if they just are keen on getting pregnant, we just do an IUI. Sometimes you may have to do it under anesthesia because she will just not allow for us to put even the smallest of the cusco speculum or a sim speculum. So now this is a case of an ejaculation. Quickly, can we just have, we have sometimes where the husband says that or will not be able to produce on the day of IUI. So what is it that we need to look into and keep everything ready?
Retrograde ejaculation.
It could be retrograde ejaculation, or there's complete anejaculation. Okay, that it could be some nervous injuries, but so it can be orgasmic anejaculation or anorgasmic. So there's a failure in orgasmic diabetes after TURP, and anorgasmic is failure to attain orgasm as well as ejaculation due to injuries. But how do you manage a case of anejaculation? And I think especially fertility clinics, we need to be ready with all. So what has been your experience? Anybody can speak. Krishna, you're into IVF, so
yes, ma'am. Like I said, when it comes to ejaculation, especially when it comes to treatments, I think I always collect samples before. And for sexual therapy, I would refer them to, because they are often, especially in the South, they are quite hesitant to talk to us. So we definitely refer them to a male doctor to speak to. But yes, it takes up a lot of counseling, drugs such as ephedrine, imipramine, vibrator therapy. Yes, all of us, I think as infertility specialists, it saved our skin many a time.
Yes.
Especially when we force them to get an ejaculate, I think it saved the thing far too many times.
Absolutely.
So yes, that provides a strong stimulation to get an ejaculate from them.
Yeah.
And I, to be very honest, I've just had one case of neurological injury, and we had done a TSA. So I didn't have it was an exit. So I don't have
Dr.
much experience.
Jairani, what has been your experience, personal experience?
So I think it's a very good point that they have always a lot of problem in the ejaculation. It's a situation ejaculation failure they will have, or the anejaculation, which may be a cause for the infertility. So ideally speaking, as pointed out, we have to give them a drug. We can try for vibrator therapy. We can even go for an electroejaculation. And there are even nowadays a modern gadgets of this electroejaculation which is made very simple, that in a it's an ejaculatory room. There's a model there where you connect and it automatically collects the semen sample like a breast pump. It cases. So such sort of things are all available. And very importantly, as pointed out by Krishna, that we should have a backup sample of a semen collection, which was done earlier to prevent this type of a problem happening at the time of an IVF or an IUI. That is also very important. Many times when they have a spinal injury or a paraplegia or a quadriplegia, they have to go for electroejaculation.
Yes.
Nowadays, for ejaculatory dysfunction, HIFEM chair is used for pelvic muscle enhancement.
Okay. All right. That's nice. So this is about deep dyspareunia, and we are seeing a lot of endometriosis nowadays. I will not go into this because this is a topic by itself, and probably I don't think we need to cover it in this forum. But we need to remember that it could be a case of severe rectovaginal nodules, and good transvaginal sonography, MRIs, and proper surgery will really give them relief. Are there any other points, Dr. Jairani, in chats that are there any questions that have been asked? Otherwise, I have about 45 minutes are over, 50 minutes. Are there any questions from the audience or from the chat? Or anything else that anybody would like, any of the panelists, expert panelists would like to, cover, which has been missed?
In dyspareunia, nowadays I'm using PRP preparations for repeated infections. It is giving very good results.
So where do you inject PRP? In the
vagina.
In the vagina. And how often?
After the laser therapy.
Okay.
We use diode, and then after that we inject the PRP and also spray with it. It is done every monthly for 3 sessions, and we can repeat it after 6 months or 1 year.
Okay, interesting. Any other point? Any other panelists would like to educate? Or
sexual dysfunction is more common after first birth, result in secondary infertility.
Yes, good point, noted. So that could be basically because of maybe laxity of the vagina, which was covered by Dr. Sunil Jindal.
Yeah.
That is what you're trying to tell, Dr. Yeah.
Actually, laxity of vagina is not only after birth, but also due to the hormones relaxin that relaxes the muscles and ligaments. So not necessary that vaginal deliveries cause the laxity. Even cesarean, after post-cesarean also.
Episiotomy related pain, dyspareunia might be the reason, or it might be due to the emotional things, all these cases. The intimacy is lost between the couple in most of the cases.
Yes. Or the female thinks that she is not all that attractive to her partner, or the vice versa also. So
poor body image, feeling of poor body image.
Yes, I think it's a very.
I think Professor, he's my undergraduate teacher as well, Professor Rao. He was saying he had a patient.
Yes.
It was a couple. The main problem was he was always chewing pan. So the wife just couldn't bear herself. They came for infertility and they were asked to go to him. But he realized she couldn't take this thing of chewing pan all the time. So, it could be basically when infertility is easier to treat. than sexual therapy. But, I mean, it is one of the incidental findings, what I have seen in my practice. But basically, we need to know when it comes to sexual therapy, what the couple want out of the relationship. And I think that's where our the female sexual dysfunction, there are people who are very happy without having an actual coitus or a penetration. They haven't had orgasms for the whole entire life. So what is important to the patient? Like this patient, I said, Madam, I had to do IUI under anesthesia twice for her. So, and both the times she has got 2 children now, but she's still quite happy. She was 32 kilos, which she became 48 after her pregnancy was over, when I had done second time. She was that depressed. So that's not going to go away. So I think that's important for us. Infertility is the easier part to treat than the sexual dysfunction.
Yes. So you want to give your patients all the pregnancy in the bedroom, in the laboratory, not in the bedroom.
That was just one case because they decided no.
To have babies from the bedroom, not from the laboratory.
True.
That is the talk mainly we are now into, Krishna. It is not the other way around. So we want more the babies from the bedroom, not by the...
True.
That's the ethical point. That's the ethical point what Sudha quoted. Because many times when you come across with a sexual problem, we immediately ask them to go, okay, we'll do IUI. But we don't look into the basic problem and correct them a standard of living, which is very important between a couple. For a marriage, first fruit is the sex. That is a very important one which bonds them, the relationship, intimacy, everything. Then comes your pregnancy. So in your sexual health, very important that you have to give them a natural way, which is always a bliss, for which only we are looking into this.
And I think it's really important to put this stress home. Bringing a baby into your bedroom will not finish off all your problems. I think that's so important to tell the couple.
Yeah. Problems not just because of sexual issues, but even other problems. I think having a baby is not the answer for everything.
Answer for
for
marriage to work.
Interpersonal problems. Yes.
Dr. Sudha, Madam, and the panelists. Like I do have a patient now. Like she's married for 17 years. She has gone through all the, fertility treatment. She was okay till then. Like she had some 3 or 4 IVF, 8 IUIs, and now suddenly she has developed vaginismus, and which is more of superficial, not a deep vaginismus. And now they are not wanting any IUI, IVF any further, and a single finger PV is very painful. So what are the options you will suggest for that? It's very unusual for a lady who's married into 17 years, suddenly developing vaginismus.
No, she must be very old, yeah. She must be now 40 plus.
Madam, she got married at 20, madam, and now she's 17 married. Yes, so she's 37. 37,
yeah.
37, and
she has
still
developed
wants
a
the pregnancy.
psychological problem because she wants to wave off that I don't want to have a baby. That's what the psychological thing that she wants to. Fertility treatment.
They want to come
that she doesn't want to allow anything to be done. So ideally, she need a cognitive therapy and a sensate focus therapy that will help her more for the psychological problem. It's not a physical problem. It is more of a psychological therapy they need.
Yeah,
right?
I think you're right. Possibly, yes. Probably it is her way of, not wanting treatment for infertility. She's had enough.
Yes.
And that is her way of, just telling a no to all that. Probably you need to really ask her, and maybe she'll tell to the doctor, or maybe she'll just just tell it to her for close friends. So I think this is a tough nut to crack. You may have to really find out, because sometimes they are
a form of PTSD, madam, post-traumatic stress disorder.
Yes,
you can definitely put it into that category.
Yes. So I think a proper psychotherapist who will look into and who will give her good amount of time, maybe few sessions, and then probably she would come out as to what it is. They will come out with what is going on inside them sometimes in this counseling sessions, is what I feel.
A few years back, even we as gynecologists wouldn't speak about the sexual disorder. So we have made a way now, actually.
So with that, we will conclude.
Yes,
I hope I've done justice.
Absolutely, that's really amazing. Great, Sudha.
Thank you so much.
So we have covered everything. You have covered everything in a nice and beautiful way. And definitely it is a very important that you packed everything with proper practical tips, which is a very beneficial for most of the audience as well as the fact, people who practice this also. Thank you so much, Sudha.
Thank you, Sudha, madam, and the panelists. I would like to invite the chairperson to give a closing comment. Dr. Vivek.
Jayarani madam and Sudha ma'am, thank you so much. Madam, you are supposed to give a comment. Jayarani madam, you're muted.
So I think I've told enough that it is a real, very good, interesting. Everybody, you had very good interactions and you have shared very many thoughts of your practical experience. And definitely infertility and sexual medicine is really a stressful one for both the couple, because we have to give them a natural pregnancy, and to get this, we have to do a lot of counseling, lot of encouragement, and lot of couple-oriented treatments. Those are all very important. And definitely, if it is done with a good cooperation from the patients, definitely we can get this corrected.
I should thank Dr. Jayarani madam and Sudha ma'am, because in 2019, when I was president of Solapur Vijay Society, both of you had come and you have created interest in interest in the sexual medicine since then. Thank you so much.
I remember, and you had a very good public awareness program.
Also. They had a very good public awareness program. It was amazing, very interesting.
I think not a single person was outside the hall.
It's about 2 to 3 days, and maybe after 3 years after completing, after 3 years after I've finished, Dr. Jayarani has again pulled me into this.
You will be coming here after frequently.
I was wondering whether I'm the right person because I'm so much into other work. But thank you again and wish you all the very best.
Thank you.
Thank you, ma'am. Thank you.
Thank you. And thank you all the panelists for their expert opinion. Thank you.
Thank you, ma'am. My screen is visible. So we'll go on to the next topic for today's discussion, menopause and women's sexuality. So, sorry. I would like to invite the chairpersons for this talk, Dr. Meena madam. She has done her MBBS and MD, and madam is a professor from Solapur, and she's a consultant ops and gyne in Gunjatika Nursing Home, Solapur, and also in SNNJ Ayurved Hospital. And she's participated actively in many social activities and special interests in NDVH. I will also invite our next chairperson, Dr. Sumant Kulkarni. Sir has done his MBBS, MD, DNB, and he's been trained with Dr. Rajan sir and trained in Manipal University with Dr. Pratap sir, awarded the Young Talent Award at Foxy Siliguri, and executive professor of in BMMC Solapur, and also executive honorary associate professor, UGPG examiner, consultant, Swanand Hospital Nursing Home, Sangli, and he's presented many papers in Foxy and national conferences. And Dr. Madan sir will be the expert. So I would like to invite our chairperson to introduce our speaker.
Hello, am I audible?
Yes, sir. Yes, sir.
Yeah. So at the outset, let me thank the organizing committee for giving me this best opportunity to participate and share the session on menopause and sexuality. Today we have Madam Mahinder Ahuja. She's a director of Ahuja Healthcare Dental and Infertility Center. Madam has a vast 40 years of dedicated service for the women from adolescence to menopause. Madam Ahuja is a founder member in the year 2013 and 14 of South Asian Federation of Menopause Society. She was the Secretary General again from 2014 to 18, and now Vice President since 2018. Madam Ahuja has more than 100 publications on her name. She's the author of the book Early Diagnosis and Treatment of Premalignant Lesions of Cervix and Step-by-Step Management of Menopause. She's editor-in-chief of Journal of Menopausal Health. So we have got a stalwart with us. So I would like to present Madam Mahinder Ahuja. Madam, please.
Thank you for the kind words to my chairperson, especially Dr. Suman, and thank you to all the societies who are holding this conference, EMOGS, Tamil Nadu, and South India. And special thanks to Dr. Jayarani for inviting me here. And before we start, I wish her best. I think she's the best candidate for this committee of sexuality. And I'm 100% sure that you should win. And our all wishes are with you. Can I share my screen now?
Yes, ma'am. Yes. Yes, ma'am.
Yes, yes, yeah. So good evening to everybody. Now this topic is of utmost importance.
Ma'am, we can't see your screen now.
I'm going for the, yeah, now it's okay. Yeah, thanks for giving this topic to me, which is of utmost importance, because a healthy and satisfying sex life is an important component of overall well-being for many midlife women. Multiple studies.
Sorry to interrupt, ma'am. We are not seeing your screen now.
Oh.
We initially saw that, but now we are not seeing.
Yeah, I think I'll have to go back again and share.
Yes, ma'am. You just have to minimize your PPT and come back to Zoom and share your screen again.
It's a problem.
Yes, ma'am. Yes, now we can see you.
Can see you?
Yes, ma'am. Slideshow. Perfect, ma'am.
Okay, now it's okay. So, we are living in an aging world. So, healthy and satisfying sex life is the utmost importance. Let me minimize it. Just 1 minute. Okay. Okay, I'm actually, yeah, this was hiding my view. So we are living in an aging world, and the first slide, yeah. A healthy and satisfying sex life is an important component of overall well-being of many midlife women. Multiple studies have shown a strong positive association between sexual function and health-related quality of life. And we are living in an aging world. Midlife women are increasing in number, and number of years the women have to live in midlife is also increasing. So almost more than 1/3 of life is being spent in midlife now. So sexual well-being is very, very important now for the quality of life issues of these women. And women are suffering from all symptoms of sexual dysfunction in this age group, and especially with the men now getting treatment with phosphodiesterase type 2 inhibitors, and they are living longer. So the women have the expectation to maintain a sexual functioning along with the sexual healthy life also. So screening for female sexual concerns is often shortchanged during the clinical encounter, and we think that it is not important in menopausal age, and we think that it can be it's multifactorial. Time constraint is there, and inadequate training of the healthcare providers is there. So sexuality concerns are not being discussed by healthcare providers, and the public and the women also feel that we should bring out this issue with them, and we as health providers should be taking about these issues, and we should be knowing about these issues. And as far as the prevalence is concerned, it ranges anything from 8.9% from 8 to 14 years to 12.3% in the women age 45 to 64 years, and it continues beyond 65 years also. Though as age advances, problems increase, but the distress is decreased. So that is the main issue. But studies indicate that FSD, female sexual dysfunction, is a real burden for many women, and approximately 1 in 10 women may receive a diagnosis of hyperactive sexual disorder. So surgically induced menopause, the incidence is more, 26%, as versus to non-surgical women, because the testosterone is reduced drastically after removing the ovaries. But the same thing does not happen in the natural menopause if you remove the ovaries, because already they are non-functioning. So how menopause causes a midlife sexual dysfunction? Because the changes occur where the intensity and duration of stimulation needed for sexual arousal and orgasm increases, and there is inadequate lubrication, vaginal dryness, dyspareunia because of the hypoestrogenic state. And survey data regarding symptoms related to vulvovaginal atrophy show that this syndrome is almost in 50% of the women is found. And menopause affects sexual dysfunction. Along with these reasons, social conditions related to midlife or midlife stresses like divorces, lack of partner, job loss, declining health, and women living longer, their sexuality issues are now taking a front place. The other factors have also been looked into, and decrease in androgen is one of the important causes. And then pelvic organ prolapse, I think Dr. Sunil Jindal has taken it nicely, that why the POP is causing the sexual dysfunction, connective tissue degradation, pelvic denervation, dyspareunia. So any one of these can cause the devastating sexual function. So what is sex response cycle? So that was defined in 1960, I think. And it started with the excitement, plateau, and orgasm and resolution. But later on, it was recognized that desire is also important. So desire was also added up. And later on came the other factors, seeking out being receptive to the partner's stimuli, and other stimuli also they call the spontaneous sexual derived. So it's not just the derived from the woman, also it's the other factors also which are involved. So revised definition of hyperactive sexual disorder was there, where they have diagnostic criteria in the Diagnostic Statistical Manual of Mental Disorder, 5th disease, where they said not only the lack or absence of sexual fantasies or desire for any form of sexual activity, but also the presence of personal distance or interpersonal difficulties should be there. So the patient should be disturbed. Then DSM schema uses the terminology as sexual disorders by ICCMM and ICD classification. They use sexual dysfunction, so you can use any terminology. So what has changed now is that hyperactive sexual desire disorder and female arousal disorder, they have come under the same heading of female sexual interest or arousal disorder. Orgasmic disorder is unchanged, and dyspareunia and vaginismus, they have been merged into genitopelvic pain or penetration disorder. Aversion disorder is deleted, and sexual dysfunction due to general medical condition is there, and substance medication induced sexual dysfunction is there. Then other specified sexual dysfunctions are there. So it's the manifestation of the sexual interest and arousal disorder, either reduced or absent of spontaneous desire, or reduced or absent responsive desire, but also inability to sustain the desire and interest during sexual activity, and it has to be persistent. And thirdly, very important is that the patient has to be distressed. And if there are secondary to physical or emotional abuse or dissatisfaction with the partner, or intrusion of stresses that can be affected by psychological or lifestyle changes, then they are not included. But before diagnosing HSDD, relationship issues, for example, significant relationship conflict should be ruled out as the primary causative factor. So that is very important. How to assess sexual interest? Various validated instruments, questionnaires are available. Female sexual function index. Then there are female sexual distress scale revised. Then satisfying sexual events, part of HSDD is there. So the female sexual index is more important. It says 19-item questionnaire that assess the main 6 dimensions of sexual function: desire, arousal, lubrication, orgasm, and global satisfaction and pain. I think these indexes should be there, chart should be there on our tabletop so that we can actually go into and click immediately when the patients come to us, desired domain, assess the frequency and degree of desire, female sexual distress scale revised age questionnaire that allows the measurement of distress related to sexual dysfunction and specifically low desire using item 13. And although satisfying sexual events were counted as co-primary endpoint in some studies, lack of SSE is not criteria for diagnosing HSDD, and rather SSE seem to be downstream measure of improvement in sexual desire associated with them. So what factors are there? It's not only, it includes psychological, biological, social, contextual factors also. So now the psychosocial mode is advised, female sexual function, where biology, physical health, neurobiology, psychology, socio-cultural norms, expectation, interpersonal quality of current and past relationship, intervals of abstinence, life stresses, finances, body images, everything is included in this. Biomedical factors can be hormones and neurotransmitters and their interactions. And beyond them are the psychological factors like boredom, situational stress, self-consciousness about body image, social and sexual factors like culture norms, familiar teachings. We don't have to do sex after so many, that age or the age of sannyas is there, or the joint families are there, the neurochemical transmitters, excitatory pathways, dopamine, norepinephrine, melanocortin, oxytocin, or inhibitory pathways, serotonin, opioid, or endocannabinoids may be involved, or then central nervous system from the medial orbital region can also be involved. So all these disorders which are there can be overlapping. So that is why the knowledge about the general practitioner about all these disorders is very important, about arousal, general medical condition, orgasmic disorders, and substance or medication, genitopelvic pain or penetration disorder. So they can be combined together. Like suppose if Sonia, 65 years of age, menopause, 15 years, comes to the clinic with history of burning, micturition, itching, and when pointedly asked about sexual history, she admitted that she did not have any desire for sex, but she was not bothered. Would you treat her now, or would go deeper into her study? So if the patient is not distressed, we are not going to treat, but we are going to treat her for other symptoms of menopause, which she can come to us. And the population-based studies have shown that though the incidence of sexual disorder increases, but the distress is not there. So low desire will be there. So the woman is not distressed, so it's not being reported, and that does not need treatment in those patients. So what about the role of genitourinary syndrome of menopause and sexual dysfunction? Because of the hypoestrogenic state, symptomatic vulvovaginal atrophy is highly prevalent in midlife, and as many as 45% of menopausal women are affected. But it is often accompanied by decreased secretion from sebaceous glands, and women with vulvovaginal atrophy experience pain with intercourse that leads to decreased interest and frank avoidance of sexual activity. And what the studies have shown, and in real women's view revised study, 63% of the women with symptomatic vulvovaginal atrophy reported that their symptoms interfered with the enjoyment of sexual intercourse. 47% partner women indicated interfered with their relationship, and 12% of the women without a partner reported that they were not seeking sexual partner due to symptoms related to vulvovaginal atrophy. So it is very, very important to diagnose this condition if the patient has come to us complain. So chronic diseases can also be responsible for these disorders because of the hypertension, diabetes, depression, neurological disease, urinary incontinence, osteoarthritis. They all impact sexual function, especially depression and obesity, and change body image also. So other factors which can include other fatigue or exhaustion, Or psychological causes of HSDD can be history of anxiety, depression, or low self-esteem, history of sexual abuse, or trust with a sexual partner is very important. They can lose the trust with the sexual partner. Then CVD and sexual dysfunction can be there because of the impaired blood flow, reduced physical function, or maybe reduced energy, altered body image, suboptimal vaginal engagement during orgasm, involving of the nervous system and neurological. Medications contributing to sexual are very important because this age group women are taking lots of drugs and they can cause this sexual dysfunction, especially antidepressants, benzodiazepine, lithium, antipsychotics, spironolactone, steroid, anti-androgen, GnRH agonists, anti-epileptics. So we should go into the history of medication in these women so that we will know whether the dysfunction is because of these medicals. So quality of life issue and social issues, they also impact sexual function. Education level and economic status, they impact sexual functioning. And management now will depend upon taking the proper history of all these things: physical examination, investigation, role of energy devices, and role of Kegel exercises. Now, the detailed history from the patient should be taken: low desire, including onset, duration, behavioral, close evaluation of medical history, comorbid condition, and prescription and on-the-counter drugs. They should also be taken out to other causes of low desire. So now we come to very important part, is screener. Decreased sexual desire screeners are there where the 4 questions are there in the past. So whether you had any low level of sexual desire interest satisfying to you, or your level of sexual desire interest the decrease. So if and there are other questions, I'm sorry, the timer is there. Would you like your level of sexual desire to increase? Yes. So if the yes is to all these articles, and the other causes which can be there, like operation, medication, pregnancy, partner sexual problem, dissatisfaction, relationship, or stress or the fatigue. If there is no to this, that means generalized acquired hyperactive sexual desire is there. And if it yes to all of them, but no to one of the last 5 questions, then it is not a generalized acquired condition. And it can be because of the any other reason which the patient has been mentioning, and we should look into those factors. So the first line of treatment will be psychological counseling, solely in combination with medical treatment, can be helpful to women, and it should be a couple therapy. Ideally, when you have taken the history, after that you should give a couple therapy, and behavioral exercises can be there. So very important to do the local examination in these cases, because locally you should start from the minora, majora, and clitoris, and then go on to vaginal and the upper part, whether you can see the signs of any atopic changes are there. What is the implicit model is that how you counsel the patient, you ask give the woman permission to discuss her problem, then limited information, specific suggestions, and need for more intensive treatment after that. So that is the implicit model which we go for the therapy. Role of hormone in the sexual desire. First line of treatment, if the patient is having menopausal symptoms, heart flashes, then you should give her this treatment. And if you improve with this treatment, it is okay. But then most of the time, they remain unresponsive to these things. And we have to use in those patients, if the vaginal symptoms are there, then vaginal estrogens can be given. But prior functioning relationship factors like a partner relationship, they should be checked up, and other social factors, they should be checked up. So the treatments are available in the form of cream, vaginal rings, tablets, DHA, Prestron, which is not available here, but ospamifene tablets are available, which for the dyspareunia patient, they can be given orally. So the plethora of drugs are available. Tribulon can have an estrogenic progestinic effect that can increase the libido. So that can be tried in these cases. Now, another case, like 45 years old Sunita had total hysterectomy with bilateral oophorectomy. She came dyspareunia, frequency of urine. She was given a treatment, but she did not improve with the lactation. So these With that treatment, so these are the patients who then need the endocrinal checkup, also thyroid and everything, but they need the testosterone. Sorry, my timer is on, so that is why it's going there. So in these cases, testosterone has to be given in a minimum of 300 microgram per day, and the dose has to be titrated. Now we are getting the sprays of these things, we can give it, but the basic levels of testosterone should be done so that physiological levels are not exceeded, and the effect can be there on the side effects can be on the lipid profile, hair growth, and the treatment comes on later on. So it has to be a long treatment than in there. So non-hormonal treatments are available, like Kegel exercises, I think, which have been already discussed. Rose clitoral vacuum clitoroscopy is there. Then energy devices are there, carbon dioxide laser and radio frequency, which are being tried and which can increase the vascularity congestion, blood supply, and give the some results in the dyspareunia patient, and even hyperactive sexual desire patient. The doctors are claiming that they are getting the result. Future direction are Lorixis, which is a combination of two antidepressant already on the market, bupropion and trazodone. It's phase 2 clinical trial, but flibanserin is available, where 100 milligram per day can be given. Most common side effects are dizziness, nausea, insomnia, and then other combination like bupropion, apomorphine given, and biophysical-social report model is what is required, because the women's sexual desire encompasses biological, psychological, social, contextual components, partner components. They all have to be looked into, and then simple algorithms can assist us in making the diagnosis, in screening, and further evaluation of the whether the physical problems are there or the medicational issues are there. We can prescribe the drug, the estrogen, progesterone, when hysterectomy is there. They are not helping testosterone, or the FDA approved flibanserin, but that is just approved for premenopausal women and not for the postmenopausal women. And quality of life issues, depression, everything has to be assessed. Psychological behavioral interventions can be done, and genitopelvic pain penetration disorders can be there in these patients. So these patients then first have to be treated, and then we can look into their psychological problem. If present, we have the give the complete from the genitourinary syndrome. So treatments, pelvic floor physical therapy can be conducted by specially trained physical therapists. Topical lidocaine in cases where the local lesions are there, or when the depression is there, tricyclic antidepressant, but the dose has to be adjusted, and vestibulectomy when the local dyspareunia is there, but that is rarely there. So key points are that sexual dysfunction increases with age and is highly prevalent amongst menopausal women, but most menopausal women consider sex to be an important part of their life. So we as healthcare providers have to start this discussion, go through the proper algorithm, diagnose the condition so that these women can enjoy a healthy, sexual life. So that is all. Thank you very much. Because of time, my slides were moving because the timer was set up. So
thank you, madam. That was such a lovely talk, and your slides are beautiful. I would like to invite the chairpersons to give their closing comments.
Thank you, organizers. Menopause is a change. So sexuality is a critical issue at menopause. And for many women, as many biological, psychological, social factors are related to women's sexual health, and they may negatively affect the response. So we have to handle it very carefully. Madam is very nicely elaborated and covered all the aspects of sexual disorders. Very much thank you, madam, to hear you. Thank you. Thank you.
Dr. Suman.
Thank you, Madam Ahuja. You have really elaborated the topic very well. As Madam has rightly told, in women of menopausal age, there is loss of estrogen and testosterone, which can lead to different changes in a woman's body and therefore the sexual drive. Menopause and postmenopausal women may notice that they are not so easily aroused. They are less sensitive in touching and stroking, and therefore they are least interested in the sex. Also, these low levels of estrogen result into a decreased blood supply of the vagina, and that definitely affects the lubrication. Madam has also given elaboration of the other factors around menopause, like the bladder dysfunction, like stressed urinary incontinence. There are sleep disturbances because of vasomotor symptoms. Woman is suffering from depression and anxiety, stressful conditions, and apart from that, the associated medications, which can also affect the sexual health of the woman. Thank you, madam. I would like to have one more thing. Are there any simpler things which a woman can do to improve her sexual health? Yes, the first and foremost important is be active. Do a physical activity daily. Doing regular exercise always improves the woman's mood. Go to a gym. Go and do small lightweight exercises. Always helps to make the woman cheerful. Number second, nowadays we come across so many women with smoking. Quit smoking because nicotine has been proved to decrease the blood flow to the vagina and definitely affects the effects of estrogen in the vagina. Same thing is true if she's alcoholic because she may not be interested in the sex. So avoid these simpler things. Try to have sex more often with her partner and give some more time for her for arousal, which is very important. As Dr. Jindal sir has told, pelvic floor exercises definitely plays an important role. And we also come across the women using certain vaginal irritants like bubble baths, fragrant soaps. Try to avoid them. I think if these things have been done, a woman can definitely have the sexual pleasure even at menopause. Myself and my wife were conducting counseling programs for even our friends' age groups with their wives because they have got that misconception that after the age of 50, what is left in the sexual intercourse? No, it's wrong. Husband and wife sexual intercourse must continue, and this particular thing has to be stressed to them. This particular seminar has really given us the opportunity to discuss these practical issues. So I would like to thank the organizers also and Madam Ahuja for a nice elaboration. Thank you.
Thank you, sir. Dr. Madan, sir, you have a...
Women should place themselves as the number one position in this age group. So age is just a number which should be thrown away, and they should love their body. So you try to improve on the body and love their body. So minimum sexual problems will be there.
Dr. Madan, sir? Nick.
I would like to congratulate Ahuja ma'am. You have covered everything about the menopause and how it is related to the sexual dysfunctions. And also thank you, Dr. Kulkarni sir, for the great tips and great comments. Yes, thank you.
Thank you, chairpersons, and thank you, experts, sir. I would request our secretary, Dr. Kohandevi madam, to give the vote of thanks. Dr. Jarani madam, you have anything else to add on?
Yeah, Madam Manindar madam, it's amazing that you have covered everything like a wisp of your dance. With so much of dancing strokes, you made this, your talk also running with beautiful slides, it's dancing. So it is so nice that you have been so energetic. You are a real energetic role model of Foxy. Really, every time when we see you dancing, being active in everything, it really inspires many of us. And really, we are very much amazed to have your spirit of this. You are the, I mean, I can say that you are like a icon for any women. That what you said as age is only the number, not your activity or the risk. Everything. You are an icon for that exact, I mean, exact how women should face the menopause. With a last point out, like Ulagam said, with an active lifestyle, with a lot of workout, with a lot of gymming, and also as quoted by Meena, that we should have a healthy lifestyle of eating. Whatever you said was very appropriate and it's really amazing. Thank you so much for being with us. And we really, learned a lot from you, both as your example of your life being lived, what you should what a woman should do, what you are doing is the right way. You are a set of example by living in that way. Thank you, madam. Thank you for being with us.
Thank you.
Thank you, ma'am. Kundavi, ma'am.
Thank you so much for this lovely webinar on the sexual health in women, a practical approach. First of all, I think it's a dream workshop by Dr. Jayarani Kamaraj, and we wish her all the best and an advance congratulations for her post. And we really thank on behalf of OGSSI, the chief guest, Dr. Rajendra Singh Pardesi, Dr. Milind Shah, and Dr. Revati Madam. In spite of the busy schedule, they joined us. And we thank Dr. Madan, Dr. Jayarani, and Dr. Ria, who are the conveners and the MOC. And it's our pleasure and a great honor to thank Dr. Sunil Jindal, who spoke on pelvic floor laxity and sexual dysfunction, and the chairpersons, Dr. Kiran and Dr. Manon Mani, and the expert, Dr. Madan Kamble again. And a lovely talk, Menopause and Women's Sexuality, the Need of the Hour, by Dr. Mahendra Ahuja Madam. And the chairpersons thank Dr. Meena and Dr. Sumant and Dr. Madan, who was an expert. Lovely panel by Dr. Sudha Madam, because I think it was such a learning point on infertility and sexual dysfunction. And I thank all the panelists in spite of this busy schedule who joined us. And thank you so much, OGSSI, AMOX, and TNFOG, who has given us a platform to have this webinar. And thank the Emcure department who has given us this link. And thank all the delegates who stayed behind for this lovely webinar. Thank you once again.
A very special thanks to Madan sir. Sir, without your efforts, without your, throughout 2 days, day and night, sir has been doing all the work to help me. I'm looking forward of working with you for so many webinars here, so that we make our PNFOG and your AMOX in a big way to make a lot of eye openers regarding the sexual health. Thank you so much for being with me to guide this program to advance.
Yeah, thank you, ma'am. Thank you. Thank you.
Possible, sir. Thank you so much.
We are always with you and wish you very best for your future endeavor.
Thank you, sir. Thank you so much, sir. Thank you.
We will do future, so many activities in future
we are
also.
going to do a many marathon series below, sir.
Yeah. Okay. Thank you all. Thank you all for joining.
Thank you, ma'am. Thank you.
Thank you.
Thank you. Thank you.
Thank you. Thank you.
Good night.
Good night.
All the best.
So we can stop the recording and thank you, ma'am. Thank you.
Can we get the